Okay, welcome and thank you for joining us today as we continue our exciting seminar series. I am Carlos Bosques, CEO at the Food Allergy Science Initiative, or FOSSI for short, and I'm excited to welcome you all today for a discussion with Dr. Michael Pisner from MGH, Massachusetts General Hospital, who will be discussing about rethinking when we introduce allergens and why it's important to do this early. At FOSSI, our focus is to understand, translate, and intervene with food allergies. And as a leader in food allergy research, FOSSI is dedicated to advancing scientific innovation in research to transform the lives of people living with food allergies. While food allergies impact millions across the world, understanding of the disease and the availability of effective treatments remain a limitation. Before we start, I want to remind our audience of our special 10-year anniversary celebration coming up in October, and I hope you all can join us at FOSSI 10 Summit, October 6th through October 7th at the Broad Institute in Cambridge, Massachusetts, to celebrate 10 years of food allergy research and innovation at FOSSI. You can scan this QR code to register if you like. But don't miss this great event. This is going to be the event of the year, and I hope you can join us. This year, we have prepared an exciting seminar series. We put together an exciting lineup of speakers, and throughout the seminar series, we've been discussing with experts in the field of food allergies about emerging therapies and examining the challenges and success stories in different clinical therapies, different clinical trials, and interventions throughout this series. So whether you're a patient, a clinician, a researcher, or just curious about food allergies in general, we hope this seminar series provides you with helpful information that you can use for you and your family. Before we begin, I would like to clarify that FOSSI is a science-driven and evidence-based organization, and therefore, throughout this series, our intent is not to promote any products or any companies, but instead to inform our audience on recent clinical development efforts for food allergies, and also to have the opportunity to ask questions to better understand the benefits as well as the challenges of the different emerging options. Today, I'm thrilled to be joined by Dr. Michael Pisner from MGH. Michael is a director of food allergy and advocacy education and prevention at the Food Allergy Center at the Massachusetts General Hospital. Dr. Pisner has a special interest in food allergy, anaphylaxis education and advocacy, infant food allergy management, and focuses on facilitating collaborations between the clinic, home, and school to maintain quality of life for children with food allergies. Dr. Pisner is also a fellow of the American Academy of Pediatrics, where he is a member of the section on allergy immunology executive committee. He's also a member of the American Academy of Allergy, Asthma, and Immunology, and the American College of Allergy, Asthma, and Immunology. And Dr. Pisner received his MD from SUNY Upstate Medical University at Syracuse. So, Michael, it's a pleasure having you with us today. Thank you. It's been always exciting and a lot of fun talking to you and really admire your work. So, thank you for joining us.
Thanks for having me.
Thank you. Well, Michael, I think I always ask our speakers to tell us a little bit. Our audience always wants to know more about their personal journey. So we'd love for you to tell us more about yourself, how you got to where you are as a director now at Food Allergy and Advocacy and Education at MGH. What really drove you to do what you are doing today?
All right. Well, thanks. Thanks again for having me. I would say that the big thing that has kind of brought me to where I am now is my son, Scott. I was a fellow at Children's Hospital Boston doing pediatric allergy when he had his first allergic reaction. And I thought that I was doing a good job caring for the families with food allergy, and I enjoyed it. The first 2 months of being a dad of a kid with a food allergy were life-changing for me. I was really surprised how tricky and challenging it was, how many times I made mistakes, how many times I dropped the ball, and how tricky some of the social situations were. I am the first to admit that I have some executive functioning issues, and my collaborators will second that. And to be now a dad of a kid with a food allergy puts us all in these different roles. We have to be advocates, we have to be collaborators, we have to be coordinators, we have to be educators. And so these new hats that I was wearing really brought me deep into advocacy, community education, and deep in the community for the people who I stand side by side with as a dad, but then also the people I care for. I think you're muted.
Oh, thank you. Thank you for that. Yes. Thank you for that, Michael. There's a common denominator that I'm really been impressed by in this community. Is a lot of the people that are doing the amazing work like you are really committed to this because there's also a personal connection. And so they're doing their part for the entire community and their family. And it really shows because there's a big commitment. Um, so Michael, there's different ways you can improve the quality of life for children with food allergies. Can you explain to our audience your approach on how you tackle food allergies early in life? I know this is a topic that a lot of people have been asking us because it is something that impacts many of us, and there's been studies recently, right, that early introduction has a big impact. So would love to get your thoughts and share your information with our audience.
Yeah, one of the quick things that we were gonna just kind of talk about a little bit is that supporting quality of life in a person who has a food allergy, that is going to take supporting the pillars of food allergy management. And once a kid and their family gets comfortable with these avoidance strategies and the pillar of prevention, in addition to emergency preparedness, then you take those with you wherever you go. And that's been my approach to try to help families in the community support each other in these pillars of food allergy management. And then in dealing with and teaching and talking about it with kids, making an analogy to safety rules. We get in a car, we put on a seatbelt. We get on wheels, we put on a helmet. We don't dive in the shallow end, and we look both ways before we cross the street. And then we could approach food allergy in very similar ways. We just follow these rules. We don't necessarily talk about with the kids what's going to happen when they break down, but we teach them about how to follow these rules. You always make sure that a grown up in the know reads a label, that you are taught about how to prevent cross contact in a developmentally appropriate way. You get a grown up or you get help if you have any questions or you think you might be having an allergic reaction. You wash your hands before you eat food or pick your nose. You don't share, you don't eat other people's food, and you make sure that somebody has your emergency medicine. And then one of the things that I've been doing, and one of the coolest parts of my job is that I'm kind of a glorified camp director. And we started something called the Food Allergy Buddies program, where we are teaching big kids and little kids how to work together in a community. So this is a community mentorship program, and what we're finding is that by getting the big kids in this role of being responsible and role models to little kids. So our big kids are our bigs. They are our high school students, and then we have middle schoolers who are mentors in training, and we have little kids that are our littles, and they are our K through fifth graders. And we get together 4 times a year in person, and we have these events, two at the Museum of Science, one usually at a park, and then one at ice skating. And we do activities together that the big kids lead. And this has been what we're seeing as an amazing way to support their quality of life, build their community. And so that's been something that we've been doing and finding has been pretty effective. But this is for people who already have food allergies. But could you imagine what we can do if we could prevent them? And so this is where now we'll do a deep dive on infants and babies and what can we be doing to support um, prevention strategies to keep a food allergy from becoming an issue.
That, that is great, Michael. I see we talk a lot about therapies and everything, but there's a big challenge here with food allergies, right? And part of it is also a social psychological effect, right? And having, I love the way that you've been bringing older kids to mentor the little ones, the younger ones, because it has an impact, right? Younger kids, as I always say, my kids don't listen to me; they listen to other kids that are older than them, right? So great job doing that. It's a very smart way to go. Um, so, Michael, we've been talking throughout the seminar series a lot about oral immunotherapy, early introduction. We're actually going to have Dr. Gideon Locke come in and talk about the LEAP study that provided clinical data on the efficacy of early introduction and the impact of early introduction. And we're seeing such great benefits with early introduction. But if you could actually share more details about your experience, you're a champion about early introduction. So, and you find very good ways and effective ways to promote this and to do this. If you can tell us a little bit more about your approach, also, does it apply to all kinds of allergens? Are there some pros and cons that patients and parents should be aware of?
All right, so I'm going to take you big picture, quick look, and then we'll do a deep dive and we'll go down the rabbit hole. And so many of us have been paying attention to this, that back in 2000, there were recommendations to delay the introduction of highly allergenic foods. And around that time, there was a doubling, near tripling of peanut allergy, and food allergies just continued to rise. Then, back in 2008, the recommendations to delay were retracted. And they said there's no reason to delay the introduction of typical allergens until after 4 to 6 months of exclusive breastfeeding. But they were passive, they didn't say actively do. Then in 2015, Gideon Lack and colleagues published the LEAP study, and now this was a randomized control trial that the scientific community got behind, and this gave the first very active recommendations for yes, do introduce early. And so then in 2017 came the addendum guidelines built very closely around the design of the LEAP study. They wanted to be quite close with the science because the pendulum was kind of swinging in the direction of we didn't want to people didn't want to make recommendations that weren't based on good reproducible studies. And so these 2017 NIAID addendum guidelines for the prevention of peanut allergy in the United States, notice that that's a big title and mouthful and specific to peanut, were then published based on LEAP study. Now, in those since then, it's been a little challenging to implement. Those happen to include screening steps. The sleep study itself was in kids defined as high risk, kids with severe eczema and or egg allergy. And there was definitive evidence that with the introduction in the kids who ate peanut, that there was an 81% relative risk of peanut allergy in those kids. Now, subsequently, the LEAP cohort has been followed with time, and there has been a continued reduction in peanut allergy, and their intervention of about 2 grams of peanut protein 3 times a week until the kids were 5 really had durable impact. And so now about a year ago was the Leap Trio publication showing that there was this durable impact, that there was still over 70% reduction in peanut allergy. Now, folks have been trying to roll this out. Now, one of the things that has been kind of tricky is that it it's more than just peanut. Now, the consensus approach was subsequently published that dealt with egg also and other allergens, not only peanut, and then also worked out the need for the screening step to be able to make this more practical and then encourage shared decision making where families of kids at high risk can communicate with their healthcare teams to see what is the approach going to be. Also, around the same time, the dietary guidelines for Americans, the 2025 or the 2020-2025 edition came out, and that's a pretty holistic approach to early introduction and pretty solid with them get suggesting around 6 months of life that the other allergens are added. And in the kids with severe eczema, then they suggested in that addition to default to the addendum guidelines. Now, subsequently, the dietary guidelines for Americans was changed a bit, continues to target around 6 months of life for allergens and earlier for peanut. And both the dietary guidelines for Americans, also the last edition as well, suggests that if the kid's developmentally ready, then between 4 and 6 months of life is a great target. Now, the challenge has been that talking through these and having these different guidelines that have been around. And then also, let's not forget also the recommendations from the World Health Organization and the American Academy of Pediatrics breastfeeding recommendations for exclusive breastfeeding until around 6 months of life. And so this is where, how does a family implement and how does a healthcare team talk about this? How does WIC talk about this? How do lactation consultants and newborn nurseries talk about this upon discharge? And then what's the talk in the community? So there is a lot of potential barriers, and there are a lot of conversations to be had. So that kind of tees us up to our rabbit hole. Couple things to think about in the setting of all of this stuff that we've been learning is the dual exposure hypothesis. There's more and more data being accumulated and written about and anecdotally experienced and clinically seen where the skin is the sensitizing route. The gut is the tolerizing route. That, especially if there's barrier dysfunction and inflammation of the skin, and you have contact with allergen on this inflamed skin with barrier dysfunction, then those allergens then can be presented to the Langerhans cells, which can skew towards Th2 and can sensitize a kid. If a kid is not yet allergic to a food and they eat it and they meet it through their gut, then that is thought to be the route of tolerance, that then the mesenteric lymph nodes there are going to see the antigen, and then you're going to have the T regulatory cells and things are going to chill out. So skin sensitizing route, gut tolerizing route. So if there's a family and they're eating food allergens around the baby, and you got grandma who's eating cashews, she then does a diaper change on the kid when they wake up. The kid happens to have eczema. They mash cashew dust in the diaper. They applied the creams to the kid's eczema, and they do that again and again and again and again. Then that could sensitize a child. Alternatively, if a kid is introduced to allergens early, especially between 4 and 6 months of life, before there's been significant sensitization, then this would be a great way to potentially achieve tolerance. So my team collaborated with Corinne Keat and Hopkins in a Hopkins-led study where they were looking at risk factors for peanut allergy, and ultimately, uh, findings showed that the older the kids were, closer to a year of age, beyond 6 months, and the worse their eczema was, that those were significant risk factors for developing a peanut allergy. Family history actually didn't really play much of a role in it. And so, among kids with moderate and severe eczema, every month that there was a delay in introduction of peanut increased the odds of a peanut allergy by 30%. And so there's about 18% chance at around 6 months, but then the odds increase significantly for the kids with moderate to severe eczema for every month that you wait, almost 50% by the time the kids were 9 months old. And so that window is kind of tight. And so back to this whole dual exposure hypothesis and then the timing of introduction, it's worth talking about one way I like to think about when I train folks and talk to some of the families. Um, we have different ways to prevent disease. Primary prevention is somebody doesn't have disease yet. Secondary is that you are in early stages, and tertiary is you already have established disease. So if we think about food allergy, primary prevention would be this kid has not yet been sensitized. They have not had that process that we are talking about in the dual exposure hypothesis. They have not been sensitized. They are not yet making IgE, immunoglobulin E, to this allergen. Um, the word that we're kind of using, that sensitization, when I talk about it to the families I take care of, I say that, if we're making IgE to a food, we can say they're sensitized. Just because you make IgE, you have a positive skin test or a positive blood test, it doesn't mean the kid's going to have a clinical reaction. But the longer that kid goes being sensitized and the more IgE they make, then at some point it may become clinically relevant. And so when we're thinking about now secondary prevention, this might be a kid who now is starting to be sensitized. So they may have a positive blood test or a skin test if someone tested, but they still could eat it because they haven't yet become clinically allergic. But then tertiary prevention is that we do identify somebody who does have a legit allergic reaction, and then we need to be thinking about how do we keep them from having an allergic reaction? How do we keep them from getting sick? How do we decrease morbidity? And then potentially also, how do we then possibly do immune modulation like OIT, oral immunotherapy? But it's easiest if we could catch them in primary prevention and at the same time in secondary prevention. How am I doing, Carlos?
This is great, Michael. No, you're good. One quick question there is in your classification, primary, secondary, where did you put in kids that have eczema, that don't have a food allergy yet? Will there be a primary or secondary or somewhere in between?
Well, so I think everybody will have a slightly different way to think about it, but I would say that a kid with eczema who now has actually started getting sensitized to a food, I'd call from the case of food allergy, if that kid had no IgE around, then I would say that we're feeding them, we're calling that primary prevention. But then if you happen to test them and they were positive, now we're saying that yes, they were, that process is starting. They are sensitized, but now we could capture them before it becomes clinically relevant.
That's great. So ideally, that's where you wanna catch them, right?
And then, as you can imagine, this is a lot to think about. And so now, when a family is going to be talking to whoever it is who's helping support infant nutrition, we have all these things to think about. We're thinking about things in the environment. We're thinking about the age of the kid. We're thinking about breastfeeding, formula feeding. We're talking about mom's diet. We're talking about grandma's diet. We're even talking about what's in the dog food. 40% of dog food has egg in it. And so if dogs are eating food all over the house, then is that going to be in the environment potentially sensitizing kids? The older they are, the worse their eczema, then perhaps that process goes faster. So when then the healthcare team is trying to think about the timing and supporting families in early introduction to try to prevent, think about all the things that need to go into the conversation. And then the trick is that the conversation for one family is going to be completely different than the conversation for another family. And so
That
this, I think, has been part of what the challenge has been for rolling this out is that a cookie cutter approach, one guideline isn't going to necessarily work because babies aren't cookies. Every
yes.
baby's different, every family's different. And even the structure of the healthcare team and access for potential screening is going to be different. And so, how are we going to support our clinicians? How are we going to support the people who now are engaged in infant nutrition to be able to work with the families and just get this show on the road and just feed them?
Yeah, we tend to generalize, but in on the other side, I know in the research world, we talk about endotypes and everyone having being different, right? And different reactions to different allergens. And so to your point, it seems like since everyone is different, yet we try to generalize and provide a cookie cutter approach. So how do you deal with that? How do you deal with all the large diversity of people and their diets and their environment and what they eat and their background?
All right, so that is, I mean, that's going to take shared decision making. So being able to then have enough time to be able to then understand what the different risk factors are and what the where the family is, that is going to be tricky. Now, the problem is this. You show up to me, I'm an allergist. That ship has sailed. And my wait time might be quite long. And so remember the data that I was sharing before that every month you wait to introduce peanut in a kid with moderate to severe eczema increases the odds of a peanut allergy by 30%. Now, if someone wants to start their voyage to see an allergist and they put them on the wait list, but if my wait list is 5 months and they started their voyage at 6 months, by the time the kid gets to me, they're 11 months old. Now, they have a better than 50% chance of already being allergic to peanut. Now, let's say I skin test them and then I decide that I want to do a food challenge. Now, I have to have them wait another 2 to 3 months to get on my oral food challenge list. So, this is where we're kind of, once you get to an allergist, it might be a little late. The other challenge is that 50% of allergists are internal medicine trained. And there are a lot of allergy teams that aren't really kind of set up to be able to handle bringing in babies for food challenges. So this puts a lot of the onus and pressure back on primary care. And so primary care, family medicine, pediatrics, MDs, NPs, PAs, they're all going to be front lines in having these conversations with the families. But now here's the thing is that these folks are talking about firearms, trampolines, vaccines, do they have time to have shared decision making with families? And that has been the challenge. This is where WIC is really positioned really well. Women, infants, children, or really anybody who's focused on infant nutrition, because they have the time to have these conversations and they can have continuity in conversations in the 15 minutes where primary care needs to go through all the things that are going to maintain a kid. How are they going to be able to have shared decision making when it comes to early introduction, and help be reassuring and not terrifying or aloof?
Yeah, and too many decisions, and especially I can imagine for a new parent, right? That it's just learning how to deal with so many things at the same time. It's a big issue. It's a big issue. Um, Michael, so at least early introduction has now we move from avoidance to early introduction. That's great. There, to your point, there's a lot of challenges because not everyone is the same, and there are many endotypes, and people react differently, and age is a challenge. But so there's progress on that front. What's missing? What's missing in the equation so that we could make this even more effective than it is?
I think access is one of the things that I was getting at. Access and time. So figuring out how do we give the primary care teams and others who are dealing with babies when they're still young, how do we give them the tools to be able to support families? How do we normalize feeding? How do we make this early introduction something that like feels right and easy? And then how do we get access to allergists or allergist guidance when we need it? And how do primary cares find out how to work with their allergists? This is kind of where a lot of my team's work now has been kind of put towards trying to facilitate collaborations between primary care and allergy and trying to facilitate communication between families and their healthcare teams, primary care and allergy, and then also looping in WIC and everybody being on the same page. And so our team is now in our 6th year of creating a clinician support platform for primary care, and then also for families, also for WIC, and also for the newborn nursery. And we call it the FAMPIT platform, Food Allergy Management and Prevention for the Infant and Toddler. And on it, there are electronic medical record templates that a team could put in their electronic medical record, in their after visit summary. We have training for primary care. Then we also have family facing resources, and we're soon to launch a family facing site in English and Spanish. And we're shooting for the 5th to 8th grade reading level. And one of the newest things that we are now offering since January is something called office hours, where a team can sign up and they get me and my team, and we help work with them and perhaps their team leader to roll out some of the early introduction and early support for infants and toddlers to their communities. One example, one of my colleagues, an allergist, invited 43 pediatricians, and we kind of co-hosted and then helped them roll out some of the resources and tools to help support their community. And so this is something that we'll see ultimately what the impact is, but I'm excited for it because just like the cookie cutter thing with babies, uh, a system is going to be different. If you're in rural Maine, you're going to have different challenges and access issues than in Boston. And even one Boston site is different from another Boston site. And so the hope here is that different teams can figure out how to work together to accomplish the same goal, which is normalizing feeding and supporting families.
Excellent, excellent, Michael. Um, I want to make sure that we take some of the questions. So, and we have 10 minutes for Q&As. Before we go to the Q&A session, I want to remind everyone, I know I always get the question of how can we help? As you know, FOSSI is a nonprofit organization, and so we need all the support we can from our community. So you can donate follow us on social media, join our webinars, and you can host events. So please feel free to connect with us using this QR code on display right now. We really appreciate everyone's support. I want to also remind people that our next seminar is going to be with Dr. Jennifer Maloney from Regeneron, who will be talking about dupilumab and the dual battle with food allergies and EOE. This will be Tuesday, April 7 at 12 p.m. So I hope you can join us. Please make sure you register for it. And we look forward to a great discussion. So, Michael, a few questions. This is fascinating because we've been talking a lot about the therapies and the trials, but therapy is as helpful as it can be when it's used and when it's used in the right manner. And any intervention, it is as helpful as it is used correctly. And I think in your case, that's what you're focusing on, right? And trying to intervene at the right time, which is so essential. You talked about the earlier the better, and entering through sensitization through the skin. How about in your practice, do you do something about emollients and the treatment of the skin and the skin barrier to also prevent further stimulation through the skin? Can you tell us a little bit more about how you think about that? I know the data in clinical trials of emollients in food allergy has not been so great, but what are your thoughts and what do you do with that?
Well, I mean, one of the things is managing eczema well is something that everyone's going to get behind. And being able to help families identify potential eczema and then treat eczema aggressively, perhaps before that sensitization process. And so I happen to love co-managing with pediatric dermatology, co-managing also with primary care. And I think that identification of kids with eczema as early as possible is going to be where we're going to really have a lot of help when it comes to preventing then potential food allergy. Because if that sensitization process, so if there's a child who's got terrible eczema at 1 month, at 2 months, obviously we're not thinking about feeding yet, right? We have plenty of time to now get that kid managed, get that kid treated, use emollients. Be cognizant about some of what we talked about with the dual exposure hypothesis. And so that 1 month old or 2 month old with rip roaring eczema, if the family's all eating cashews around that kid, and obviously that kid isn't going to be having any solids, but that kid might be sensitized with time. So if people are careful with a good hand hygiene after they eat allergens, they wash their hands before handling baby skin, and you take care of that eczema nice and early, then hopefully that kid will then have a very successful early introduction without that sensitization. And so that's again, I guess the take home point here is get help for managing eczema early, but then also know that when the kid has significant eczema, that's where that 4 to 6 months of introduction time is really going to be important and key. So having a plan and everybody feeling good about it and figuring out how they're going to introduce during that window is going to be good. And if the kid's eczema was picked up at 1 month and 2 months, now there can be planning.
That's great, Michael. It seems like one person in our audience, Hannah, was just thinking about the same thing. We're thinking about the same way, where she's asking what are the realistic options for a 2-month-old baby with moderate eczema? Is it how realistic it is to go into full prophylactic allergen lockdown for the next 2 to 4 months? Will it be more realistic to identify and treat the underlying cause of eczema? And specifically, she's asking about natural dirt or exposure a baby to natural dirt. What are your
All
thoughts on
right.
that?
All right. So first off, I would caution nobody has to go on lockdown with allergens, right? And so that is where just thinking about a little bit of so people can continue to eat their allergens in their house. They're just going to want to be careful about hand hygiene, especially after they eat it. And you could sit down at your kitchen table and clean up after yourself, but you wouldn't necessarily want to walk around the house eating things on the upholstered furniture, well, then the baby mashes up. So I would say that you don't have to go on lockdown. You can have very reasonable environmental kind of practices. Now, as far as the microbiome and supporting like good bacteria, there are more and more studies showing that the microbiome really does have influence in the development of allergies and ultimately also with eczema. There are no studies that necessarily identify like a specific probiotic that can be given to somebody, but definitely hits to the microbiome has have been shown to increase the association with food allergy. And things that the community right now are seeing as beneficial are diet diversity, is avoidance of highly processed foods, and pregnant and nursing moms having a diverse diet of healthy fruits, vegetables, fats, proteins. Um, there was another element to your question, Carlos, that I'm dropping the ball on.
No, no, I think you cover it was more of natural dirt, but I think with this you're covering this. Um, there's another question of what is the recommended dose of allergen exposure for infants to take during primary prevention? Will the dosage increase over time?
All right, so I mean, this is where we kind of take science and then we apply it to a real life baby, right? And so the LEAP study gave phenomenal data, and they really like when they designed it, it was kind of like a go big or go home mentality. 2 grams of peanut protein 3 times a week until the kids were 5. It worked really, really well. But they didn't do the study 1 gram 3 times a week. They didn't do the study 2 grams 2 times a week. So we don't exactly know what their outcomes would have been if it were different. Um, and so this is kind of where talking around it is sometimes something I do with the families that I take care of. I say 2 grams 3 times a week for peanuts seems to work really well because that's what the studies show. But 2 grams twice a week is probably really effective too. And it's better than 2 grams once a week. I would then recommend to people to keep at least 2 grams in once a week. So there was also a study called the EAT study inquiring about tolerance. And so this was on younger babies. Now, it is not recommended that solids be introduced to babies before 4 months of life. But in this study, as early as 3 months, allergens in a rotation were added to the kids' diets. And their goal was to get 2 grams of peanut protein in, 2 grams of egg protein in, 2 grams of other allergens in on a weekly basis. Now, the per protocol group, the kids who actually could keep up, because they're like little magoos, like they're not like it's kind of hard to do. But the kids who could eat 2 grams of peanut weekly and the kids who could eat 2 grams of egg weekly, they had significant reduction in the chance of developing an egg and or a peanut allergy, respectively. So I kind of anchor 2 grams weekly as per eat with the little ones. And then the LEAP study used 2 grams 3 times a week. It's a lot. So somewhere in between probably makes sense. And then what I have families also then do is you think about the age of the kid. You got a kid who's like 4 month old, who's reaching for food, interested, decent head control, showing that they're developmentally ready for solids. And they start a infant cereal, they're doing well with it. They get a pureed fruit, they're doing well with it. Pureed veg, they're doing well with it. Great time now to scramble up really well done some scrambled egg and get that kid to try to eat some of that. If you could get to a third of an egg, which is about 2 grams, wonderful. But if they're really little and they're still getting skilled at this, you don't need to get to your goal yet, but you're going to want to try to get that food routinely in and keep it in routinely. That's the special sauce is getting a developmentally appropriate quantity plus a relatively reasonable frequency in. And this is where I've been recommending to people to think about the allergens that they're enjoying in their family. And so this is where matching what is appropriate for the family and that family's culture with that kid is going to be perhaps the special sauce. So if there are foods that bring that family joy, those would be nice foods to add to baby. A couple of the rules: no honey until the kid is at least one, no loose nuts or seeds until around age 5. I'm a chocophobe, so I kind of push it back, but some people might go a little earlier. Then no added salt and sugar to reason, no high mercury fish, nothing raw that could bring foodborne illness, like no raw beef, no unpasteurized dairy, no raw seafood or shellfish. But then otherwise thinking about the foods that a family really enjoys eating. So if the family loves cashews and the family loves sesame and the family loves hazelnuts, those would be reasonable foods to put in developmentally appropriate forms that are non-choke risks and get them in that kid's diet. But if the family thinks that any of those are revolting, then adding those foods in the kid's diet may not really work out practically. So being able to match it with really what the family is eating, what is in the environment, what might be on the hands, and then get that in the kid's mouth in a developmentally appropriate way in a frequency that feels reasonable is ultimately kind of the message to send. That was a very long answer to a very quick and simple question.
No, nothing is simple in this space, Michael. We really appreciate it. I know we have more questions and we're out of time, but please send us an email directly to Fossey or to Michael, and we'll be happy to provide more information and answer any questions. We'll try to answer some of the questions that we have in the Q&A here as well. But Michael, it's been a pleasure talking to you, and I think just mixing the implementation with the research that happens, that we talk about therapies, we talk about intervention, we talk about prevention, but really talking to someone like you, that it's at really at the crossroads of taking that general recommendation, like you call it the cookie cutter approach, and then dealing with everyone and their own history and their own realities to try to make this as effective as possible. It's a big challenge. So, really a pleasure talking to you. With big admiration for what you do and trying to help this community. And so, to our audience, please feel free to reach out directly to Fossey or Michael if you have more questions. Uh, Thank you again, Michael, and thanks to everyone for joining today. Hope you can join us at our next seminar.
Thank you. Thanks for having me.